To the call today. My name is Matt Handy, and I am CCSN's webinar coordinator. And today I'd like to welcome you to our webinar, which is titled What You Should Know About Drug Approval Bodies in Canada 101, the elevator length pitch. Now, this is a primer for attendees attending the November 15th to 16th Drug Pricing Policy Summit, and for anyone else who just wants a review of these systems for their interest. Now, today the webinar is going to provide a broad conceptual blueprint of federal and provincial territorial public health policy structures across Canada, describing the legal framework, government responsibility centers, and their mandates for treatment access with reference to specific opportunities for patient engagement. Now, during the presentation, you'll have the opportunity to ask questions, so you can just click that questions box on the right side of your screen, and you can ask questions at any time, and we'll try to get to them all before the end. Now, for those of you who haven't attended an earlier webinar, this webinar is hosted by the Canadian Cancer Survivor Network. At CCSN, we work with patients, survivors, families, partner groups, and sponsors on collaborative action to identify and remove barriers to optimal patient care, to ensure access to education and action opportunities, and survivor involvement in healthcare decision-making, and to support evidence-based research on ways to promote equal access to early diagnosis, timely treatment, and follow-up care. If you'd like to learn more about CCSN, you can visit us on our website, www.survivornet.ca. Now, before we begin, this webinar is going to be available online tomorrow. There'll be a full video on YouTube as well as slides, which will be on our SlideShare account, and links to both of those will be sent out to your email tomorrow afternoon. So if anybody was wondering about that, that's where it'll be. So now, without further ado, I will hand it over to Louise Finder, who's going to take us through the first part of this presentation.
Thanks so much, Matt. And I'd like to say that this webinar, while is being sponsored by CCSN, is in partnership with two amazing partner groups, the Save Your Skin Foundation, now I'm going to say it right, melanoma organization for patients across Canada, and Sabrina Hanna is joining us to present, and also the equally marvelous Antonella Scally, who's joining us from the Schizophrenia Society of Ontario. They've really become wonderful partners, which might not be what they'd say about me, but that's why I'm getting to talk first. So, as many of you may know, our three groups and other partners are putting on a 2-day educational and working summit with regard to drug pricing policies in Canada. And my hope, and I think all of the organizers' hope, is that many of you will be able to attend, and that at the end of those 2 days, we will have heard some very high-level visioning and strategic planning ideas and even tactics for our groups for the future in relation to the sustainability of our drug system, both public and private. In order that everybody will not be bogged down at that meeting with kind of catching up on the 101 about some of these organizations that we'll present, because you may not know them very well. We're putting on this webinar so that when we come into the seminar, everybody will come into the kind of off the ground running. So that's what we're doing, and that's why we call it the elevator length pitch, because we only have a few minutes to talk about an awful lot of organizations. So the next slide will start us off, and I'm going to go through this very, very quickly just to position pharmaceuticals in Canada. And the take-home message here is that approximately 40% of pharmaceuticals in Canada are paid for by the public sector, and the rest by the private sector, but that would be a combination of private insurance companies, and interestingly enough, and this is a very important part for many of us who care about access for everybody, at least we hear numbers from anywhere between 10 and 24% of pharmaceuticals are paid for out of pocket. either because people have no coverage, they are undercovered, or as I call it, sometimes they're theoretically covered. That is, they have a right to a particular reimbursement system from the public payer, but they don't have the money to pay the deductibles or copays that actually let them get into that system. So keep that in mind as we go. So if we look at the next slide, we're going to see that if we drill down into the prescription drugs, there's a lot of talk about our prescription drugs and how expensive they are. And I'm not going to be the one to say that they are not, absolutely not. And that they put pressure on our drug budgets, absolutely they do. But if we really look at the entire pie for health expenditures in Canada, we've got some other pretty big players, such as the hospitals, other institutions, administration, physicians, non-profit, they're all part of this mix. And while my message always from this slide is absolutely, let's do the very best that we can in the prescribed drugs budget to be most effective, most efficient, and equitable, and get as many drugs to people as we can. I would like to challenge the other parts of that healthcare system to develop as good metrics as you're going to see we've developed on the drug side, so that we can look really hard at potential either inefficiencies or better synergistic ways of doing work or duplication that would also, I think, behoove us over the long term. So that's my bigger pitch for the budget. So if we take a look then again and drill down even some more to the next slide, we'll see, let's move now to this complex drug system that we have to make decisions about how to get drugs to people and which drugs to get to people. So we start with drug development, of course, which could take anywhere from 7 to 10 years at least. Then assuming that the drug developer thinks they have something that the trials show are worthy of approval for sale in Canada, they will send it to Health Canada. Health Canada, I'm going to make a few little comments here about Health Canada, and I'll do more later. Health Canada accepts phase 2 trials for sale. I'm wanting to mention this specifically because unfortunately that is not happening very much at the other levels that have to approve drugs, and that is a problem that I hope we're going to talk about to some extent at our summit. So that's just a little sneak preview. So Health Canada, and we'll talk about the details of what it does in a minute. Once it's done its job, we have to send the drug over to the Patented Medicine Prices Review Board. It's a board that is also federal. It's rarely understood, but recently it started a very huge consultation on its guidelines and is considering some very serious changes to the way it does its work. And a number of you, I suspect, have sent in some submissions because I heard, and I would like to congratulate the patient groups on the line for this, I heard from PMPRB the other day that they've had more patient interest in this consultation than they've ever had before. So that's wonderful. We're showing folks that we really do care about our systems and we really want to be involved in them. And that's the message they need to get. So PMPRB will will monitor a price for accessibility, and we'll talk about that in a little more detail in a minute. And at the same time, we will move on to what's called a health technology assessment. And that's, I will talk in detail about what that is, but it's a recommendation body to the provinces and to and the territories about whether they think a particular drug that has been approved for sale in Canada and found not to be excessive in its sticker, what I call its sticker price, should be considered for reimbursement on particular and on provincial and territorial formularies. We'll talk about that a little more in detail. Now, generally, hospitals have a separate budget of its own, so they make their own decisions about what to cover, so that's a different formulary. Private drug plans have a different formulary. The provinces, after things go through the health technology assessment, if the health technology assessment thinks that they are worthy of consideration by the provinces, will often, but not always, decide to negotiate these prices together to see if they can get a good price for the whole country, and that's called the Pan-Canadian Pharmaceutical Alliance. Then each drug plan makes its decision, and if you're still around and well, you get patient access. And if you don't agree with me that that's a complex pathway, I guess we'll just have to have a difference of opinion on that. So let's move and see and start talking more specifically about each of these areas. If we can go to the next slide, we'll see that another way of looking at this is you've got market authorization, which is Health Canada. You've got pricing, which is PMPRB, and also the HTA processes, which we'll talk about in a few moments, and PCPA, and then you've got the public reimbursement plans that make their decisions, and then there's individual formulary decisions at the province level. So it's another way of slicing and dicing that earlier picture. So let's start getting into the nitty-gritty on the next slide. Just another piece of background information, growth in prescribed drug spending. Everything's fun with numbers, as I call it, so I'm sure somebody could give me a slide that will say something different, but in general, I think it's generally agreed that prescribed drug spending has slowed in both the public and the private sectors since the year 2000. So it's not certainly the most expensive area of our concern, but it certainly should continue to be monitored carefully so that we're getting the best for our public and private dollars. So then so how do we sort of do that? What are the processes? So the next slide will tell you, if we can move to it, this just shows, I'm not going to take too much time with that. So let's start with what are the jurisdictions for public and private plans? The federal government does have a jurisdiction with relation to public plans, and this jurisdiction is found in pieces of legislation, in federal laws, the Canada Health Act and Regulations, Vanessa's law, which has amended the Canada Health Act, the Food and Drugs Act and Regulations, and the Patent Act and Regulations. So that's the legal framework for this work. So what does each of these tell us? So if we go to the next slide, we'll start to talk about Health Canada. Now, Health Canada reports into the Federal Minister of Health, and the laws that govern that group are the Food and Drugs Act and Regulation and the amendment to it called Vanessa's Law. The Patented Medicine Prices Review Board reports also into the Minister of Health under the Patent Act and Regulations, although interestingly, the rest of the Patent Act is actually managed by what used to be called the Minister of Industry federally. I think is now called the Innovation Minister. I like that title better. So then what do these pieces of legislation say? And if we go to the next slide, you'll see that the Canada Health Act, and believe it or not, even in today's day and age, although we've had the Canada Health Act for many years, people are still not very clear about it. It is federal legislation that requires universal access to two things: doctors and hospitals. There is a continued misconception that drugs are also universally committed by the Canada Health Act. They are not. So please don't let people tell you that. And if they do, please politely correct them. The only drugs that one can be assured of getting are those that are prescribed in a hospital, because hospitals are covered. And in fact, I put generally because there are some things that hospitals decide not to cover. And in fact, they also have their own lists of drugs, as I mentioned earlier. So you may not, in fact, get everything in a hospital, every drug and biologic and test in a hospital that you would get out in the real world if you were paying for it. I guess I shouldn't call the hospitals the unreal world, but sometimes they feel like it. They certainly work on their own time clock. So that's what the Canada Health Act says, and what the federal government makes sure is provided to all people who have eligibility under the Canada Health Act in Canada. So let's move to the next slide and take a look at what the federal government itself covers. So in terms of drugs, it covers its federal employees and retirees. It covers the military and our ambassadors around the world. It covers the RCMP. It covers First Nations on reserve through the non-insured health benefits plan. It covers inmates in federal penitentiaries, and it has a kind of joint relationship with the provinces to cover refugees. So if we go to the next slide, we'll see that so that's our Canada Health Act. And then there's the Food and Drug Act. And that act requires drugs that are approved for sale in Canada, and this is very important for us, to be safe, effective, and of good quality. And the oversight to make sure that happens is in the hands of Health Canada. And Health Canada is responsible for drugs, both brand name and generic, biologics and biosimilars, sometimes called subsequent entry biologics, although I think they're moving away from that, medical devices, natural and non-prescription health products, marketed health products, compliance and enforcement. And they have this responsibility all the way along from approving clinical trials. And as I mentioned, they will actually, if the trials are good, they'll approve them for even at phase 2, approval for sale in Canada. They post-market monitor trials to the extent that they have the resources and the information to do so. And they also have something called a special access program for drugs that are not approved for sale in Canada at the moment, but are approved elsewhere, and individually a Canadian needs them. It is possible that you can get an exemption to get that trial. It's been used in very important cases. So if Health Canada finds that one of these drugs, biologics, etc., is safe, is effective, based on the clinical trial information that they get, and is also being made in a way that's of good quality, then it will allow the sale of that drug. As one of my colleagues, Robin Lim, who's a senior science advisor in the Therapeutic Products Directorate, says, sometimes you wonder why we approve or don't approve trials. Sometimes we've got good drugs and bad trial design, which means we can't approve it. Sometimes we get bad trial design and good. If we get good drugs, bad trial design. Sometimes we get bad drugs, bad trial design. And then, of course, again, we've got a problem. And, of course, what you really want are good drugs and good trial design. So she's not criticizing anybody in particular, but these things can happen. So sometimes we scratch our head as to why one thing got approved and another didn't, and sometimes it's a combination of problems. Okay, so let's move to the next slide and talk a little bit about Vanessa's law. I'm sure you've heard about this. It was a tragic case of a young girl who died taking a medication that was approved for sale and was being sold quite properly. Unfortunately, she took it in a way that it was not prescribed, and she died from it. It really was a terrible tragedy. And in order to see if we could do something about that, at least so it wouldn't happen again, we amended the Food and Drugs Act in Canada to strengthen safety oversight and to improve reporting by healthcare institutions of serious adverse drug reactions and medical, typo, device incidents. Okay, so let's go on to the next piece of legislation on the next slide, which is the Patent Act. And this is the PMPRB's legislation. So there's three pieces to it. There's the Act itself. And just in case anybody isn't aware, and I hope you all are, but maybe I shouldn't assume this, an Act is a law, and a law must be taken to a parliament, a provincial or federal parliament, and must be voted on. So that's the strongest kind of part of legislation. And this Patent Act establishes the Patented Medicine Prices Review Board with a mandate to regulate prices of patented drugs sold in Canada to ensure that the prices are not, and this is their language in the law, excessive. The regulations give us some idea of what to look at in terms of excessivity. Now, regulations do not have to go through all the Parliament again, but they do have to be approved by Cabinet. So they are also part of a law. And so these regulations include a list, or what's often referred to as a basket of countries, to be taken into account in determining excessive drug pricing. So you can see what that list is. And then also it provides that there can be automatic increases annually for drugs sold in Canada if the consumer price index rises, and the price that it rises to will not make the drug higher than the cost of the drugs in any of these countries. Now, here's where the Patented Medicine Prices Review Board has its own jurisdiction and can do things itself not without the Act or the regulations. They must be done in coordination with those two, and they can't do something that's outside of them. But to help them decide how to look at excessivity and how to look at these basket of prices and so on, they have something called the Compendium of Policies, Guidelines, and Procedures. They are non-binding, and they are guidance that comes from the PMPRB board to the staff and to patentees, which includes information about the role of how to use therapeutic benefit in deciding if a price is excessive, for example, how to look at the basket of drugs. Do you look at the highest price, the lowest price? Do you take the one in the middle? Do you take the average? It tells you all of those things. And this is the oversight for this, as I've mentioned, is through the Patented Medicine Prices Review Board. It also, by the way, reports on generic drug price trends, but doesn't have jurisdiction over those. As you see, it's the Patented Medicine or Brand Name Medicine Board, but those are very interesting trends to follow, and I'm glad that got added to their jurisdiction. So as I've mentioned, at the moment, they are doing a very comprehensive review of their Compendium of Policies, Guidelines, and Procedures to see if they should change some of the things they've been thinking about in terms of deciding if something is excessive or not. So moving to the next slide, we'll take a look, and this, I believe, I am turning this one over to Antonella.
Yes, thank you, Louise. So I'm going to review, as Louise mentioned, and as we know, access to medications in Canada falls under both federal and provincial territorial jurisdiction. So this next section is really going to explore the bodies involved in that and the different aspects of that. Right now, I'll just give a high-level overview of two major bodies: the Canadian Agency for Drugs and Technologies in Health and the Pan-Canadian Pharmaceutical Alliance. And we'll talk a little bit more thoroughly about their roles as we go along. So CADTH is, as you may know, an independent non-for-profit agency that's funded by the federal, provincial, and territorial government. And the role of CADTH is to provide evidence-based assessments about the effectiveness of health technologies, including medications. So their role includes health technology assessments as well as therapeutic reviews of publicly available evidence for single medications or category of drugs or class of drugs. And the important thing to kind of keep in mind there is that the federal government doesn't allow its funding to be spent on the health technology assessment role of CADTH. So that's kind of an important distinction. The Pan-Canadian Pharmaceutical Alliance was created by and reports to the Council of the Federation. It is an alliance of provinces and territories, and it was started by an informal arrangement by a few of the provinces to see if they could get lower drug prices if they negotiated together with the pharmaceutical industry. And the approach was so successful that all of the provinces ended up joining the alliance, and the PCPA was formed officially in 2010. It's not a formal body, but currently it does have all 13 provinces and territories, and actually the federal government has now begun participating in negotiations. And they do have the mandate to negotiate collectively for the best pricing arrangements with manufacturers for publicly funded medications. So in addition to that primary mandate, their other goals include creating increased savings for all public drug programs, and thereby increasing access to medications, and trying in turn to improve consistency, including in criteria for access to medications across Canada. And as mentioned on the slide, they do report to the Council of the Federation, which is made up of Canada's 13 provincial and territorial premiers. And their main function is really to work together as a group on shared priorities while recognizing the differences across provinces as far as healthcare goes. So if we go to the next slide, we'll talk a little bit more specifically about the provincial and territorial role in public drug coverage. Louise had gone over the federal kind of oversight for access for public drug programs. In provinces and territories, generally they cover eligible people residing in each province and territory, inmates within the provincial correctional institutions, First Nations that are not on reserve. As Louise mentioned, some provinces and territories do have some role, especially since the cuts to the interim federal health program for refugee applicants. This may have changed because the federal government has taken on a more active role again since that they've reinstated the interim federal health program, but generally there were some provinces like Ontario that offered some support there, and then provincial employees and retirees. And just in general, each provincial and territorial government offers a drug benefit plan for eligible groups, but every province makes its own decisions about eligibility for these programs. And generally, all provinces and territories provide a catastrophic drug coverage to individuals who have only partial coverage through their private plans or have no coverage at all, or that belong to a population subgroup, such as older adults, that are likely to experience high drug costs relative to income. But generally speaking, and again, although these differ across provinces and territories, drug coverage programs fall into kind of three main categories. There are plans for individuals in the general population who have no other form of coverage and are experiencing high drug costs relative to their income. There are provincial or territorial drug plans that consist of universal public coverage for individuals that have no other type of drug coverage or insufficient private coverage. And this means it doesn't matter what the actual drug costs are relative to income levels. And then the third category is targeted to people with specific needs, so maybe specific illnesses or individuals on social assistance, and again, seniors. And most provinces and territories offer these programs in addition or as a supplement to other drug coverage programs. So the important takeaway from this is that coverage under public drug programs vary extensively across province and territories. So that means different populations may be covered in some locations and not in others. Different age groups may be covered in certain places than others. And similarly, different socioeconomic groups may be covered in certain jurisdictions and not others. And it's important to note that public drug programs generally include some direct costs to patients, including premiums, deductibles, or co-payments. and that each province makes its own, and territory makes its own decisions about the list of drugs that it adds to the public reimbursement system. So they generally review medications to decide which will be covered by public programs, and they're looking at their own drug budget when they're doing this. And each budget is very different, again, depending on things like the size of the province, how much it's decided to allocate to health overall, and how much within the total health budget is going to the public drug budget. And we talk a little bit more about that going forward as well. So if we go to the next slide, to speak a little bit more to the role of CADTH, because CADTH is important as far as provincial and territorial drug programs and the medications available through these programs, because they're a recommendation-making body to the provinces and territories about what drugs, biologics, companion diagnostics are good value to be covered under these public reimbursement processes. It's important to mention these are a guide only, these recommendations that CADTH makes through the Common Drug Review, which we'll talk about a little bit more. Although they're not binding, they're very influential. So on occasion, provinces and territories will vary from what is proposed by CADTH as far as listing a medication on a public drug formulary, but generally it is a very influential body, and it plays a very influential role in this process. And again, we'll talk about the health technology assessment, or HTA, process a little bit further along on the next slide. Thank you. So the health technology assessments are, and as Louise had mentioned, their intention is to assess the value of a medication to the public drug plans, and whether a drug approved by Health Canada should be covered by public drug health plans. These assessments are based on an evidence-based formula. If a value is determined to be good based on the formula chosen for measurement, then there can be two outcomes: a reimburse through public drug program, or reimburse the medication with clinical criteria or other conditions. And lastly, if value is not acceptable based on this formula, then a do not reimburse recommendation is made. So generally speaking, health technology assessments, both through CADTH, through the Common Drug Review, and at the provincial and territorial level, look at clinical, patient perspectives, societal perspectives, and economic perspectives, and want to balance these things against each other in making their decisions about listing a medication. The provinces ultimately have to decide if they can afford it and if this is the drug that they can afford relative to a limited drug budget. But it's important to note that from a patient lens, it's our concern that it seems as though a lot more emphasis is placed on the cost impact of listing a drug on the public drug, or the impact that listing a medication has on the provincial and territorial drug budget, compared to, for example, considering potential savings in other parts of the health system. So things like emergency rooms, not to mention potential savings in other sectors. For example, in mental health, if there are gaps to access and services, including access to treatments like medications, can lead to increased contact with the criminal justice system and increased costs to that system. But that just reflects the reality in the current system that budgets are siloed and not looked at holistically. So that's a concern that patient groups tend to have. And if we go to
Matt, would you move the slides along a little for us? There, thank you.
Thanks, Louise, and thanks, Matt. And then, so just to kind of wrap up this part about the, we talked a little bit about the Common Drug Review. Again, this is CADTH. It's housed within CADTH to review new drugs and new indications for drugs, except oncology, which is done through P-coder process, which will be talked about next. Again, similar concerns with the HTA. It looks at the clinical data, economic analysis, and the patient perspectives, or rather similar parameters that it looks at. And again, it does therapeutic class reviews as well, so it'll look at a whole class of drugs, and the recommendations are made public. An important point to mention here that you might be involved in already is that patient groups may submit information about a specific review for input, but this is only through patient groups that have been, that are registered to do so. So there's, unless a group or an illness doesn't have a patient group representing that represents them, in which case they could make a direct submission for public input. It would be done through a registered group, like the SSO is one of the registered groups that can submit information from patient groups. So I'm going to pass the next slide on to Sabrina, who's going to get a little bit more into P-coder and other elements of drug pricing.
Thanks, Antonella. So P-coder, as Antonella mentioned, is also housed under CADTH, and the Pan-Canadian Oncology Drug Review was established by the Provincial and Territorial Ministries of Health to assess the clinical evidence, cost-effectiveness, and patient perspectives on cancer drugs, and to use this information to make recommendations to the jurisdictions to guide their drug funding decisions. And an expert review committee, PERC, examines the clinical and economic information provided by the guidance panels, patient advocacy group input, and provincial advisory group input to formulate a recommendation. To help guide PERC's deliberations, a framework was created that outlines all the elements that should be considered by PERC during its review and reinforces that no single element overrides another, but rather that PERC uses the sum of all elements to formulate a funding recommendation. The framework reinforces that there is no threshold that must be met for any single element in the review. Rather, it is the individual drug, disease, and context that determine PERC's information needs for each element of the framework. And the elements of the framework are, firstly, overall clinical benefit, which is a measure of the net health benefit of using the drug to diagnose or manage a cancer-related condition or cancer care-related issue. And the criteria used to formulate that are effectiveness, safety, burden of illness, and need. The second framework is the alignment with patient values, and that's an assessment made after considering information on patient values which bear on the appropriate use and impact of the drug. And that's based solely on input provided through patient groups or by the individual patient when no patient group exists, as Antonella mentioned with CDR, and that's the same context for P-coder. The third element in the framework is cost effectiveness, and that's the measure of the net efficiency of the drug and companion technology compared to other drug and non-drug alternatives with no cutoff threshold. And the criteria for cost effectiveness includes economic evaluation, costs, cost per quality of adjusted life year, cost per life year gained, cost per clinical event avoided, and uncertainty of net economic benefits. And finally, on the feasibility of adoption into the health system, and that's an assessment of the ease with which the drug can be adopted into the overall healthcare and cancer care systems. And this criteria includes economic feasibility, budget impact assessment, and organizational feasibility. P-coder then makes the following recommendations: list with clinical and other conditions, or do not list. And then we can go to the next slide. We can talk about INESSS, which is the Institut National d'Excellence en Santé et en Services Sociaux, which is the health technology assessment agency which reviews and evaluates therapies, companion diagnostics, and the such for both oncology and other indications in Quebec. After NOC has been achieved with Health Canada, and NOC is Notice of Compliance, INESSS will begin the evaluation process for registration on the medication lists. INESSS will not accept submissions for therapeutics which have not received notice of compliance from Health Canada, which is not the case with P-coder. And there are several steps to this process which take about 6 months to complete. First is the drug product manufacturer submits a registration application to INESSS, which includes study results. And INESSS relies on this information supplied by the manufacturer and may also use any study or additional information deemed relevant. Once the application is submitted, INESSS adds the drug products to its work plan, and the plan is then posted on the INESSS website. During the 30-day period that the work plan is posted, health professionals, consumers, and patients, as well as their associations or groups, are invited to send INESSS feedback or observations on the drug products under consideration. And unlike P-coder, this is not a formal process with a questionnaire that needs to be filled out. It's really just an email that you send with information provided. So their feedback and observations are then shared with all members of the scientific committee on entry on the list of medications who will evaluate the drug product in question. The drug product registration applications are then analyzed by INESSS and members of the comité scientifique permettant de l'évaluation des médicaments aux fins d'inscription. The committee submits its report to INESS's board of directors, which ratifies the recommendations that are to be made to the Minister of Health and Social Services, and the Minister then approves or rejects the recommendations of INESSS regarding updates to the list of medications. Once they are made public, the list of medications for the basic prescription drug insurance plan and the list of medications for institutions are published in electronic format by the Régie de l'Assurance Maladie du Québec, or the RAMQ. In addition, INESSS disseminates the notice to the Minister, which explains its recommendations following drug product evaluations and the rationale. These notices are available only in French on the website. If INESSS considers that the therapeutic value of a drug product has been demonstrated, it conveys its recommendation to the Minister after having evaluated the following: reasonableness of the price charged, the cost-effectiveness ratio of the medication, the impact that adding the medication to the list will have on the health of the population and on other components of the healthcare system, and the advisability of adding the medication to the list with regard to the purpose of the basic prescription drug insurance plan. And this appraisal is part of a deliberative process involving clinicians, researchers, ethicists, pharmacoeconomists, and citizens. And then the list of medications are usually adapted 3 times a year for innovative or single source and generic multi-source drugs, and generic drugs may also be the subject of additional updates. Next slide. So as Antonella mentioned, the Pan-Canadian Pharmaceutical Alliance, or PCPA, was formed in 2010 under the Council of the Federation to join provinces and territories to negotiate prices for publicly covered drugs. The PCPA examines all drugs recommended for funding by the Common Drug Review, or CDR, and the Pan-Canadian Oncology Drug Review, which is PCODR, and then decides whether joint Pan-Canadian negotiations for the drug should occur. The goal of these negotiations was to achieve greater value for publicly funded drug programs and patients. So once a drug has received a recommendation from PCODR or CDR, the Alliance decides whether to negotiate jointly for the drug. If it decides to do so, one jurisdiction assumes the lead on the negotiations with the manufacturer. If they reach an agreement, the manufacturer and lead jurisdiction will sign a letter of intent. Once these negotiations have concluded, each participating province and territory makes their own final decision on whether to fund the drug and enter into their own product listing agreement based on the letter of intent with the manufacturer. PCPA negotiations for brand name drugs are currently being led by Ontario, with Nova Scotia and Saskatchewan taking the lead on generics. And in April, Quebec adopted a bill that would allow them to negotiate drug prices, permitting them to participate within PCPA. It should be noted, though, that the role within PCPA is unclear. Neither PCPA or Quebec have provided any information on how this partnership would play out and how negotiations would take place, with INESSS and PCODR making different negotiations on the same drug. So on the next slide, once PCPA has negotiated a drug, each province then has to determine whether they're going to list that drug. So in order to benefit from the negotiated price, the province must agree to sit at the negotiation table with PCPA prior to the start of the negotiations, although this may not always be the case. And even if they have participated in the negotiations, they're not obliged to include the drug on their formulary. Some provinces automatically list, some may wait until they have the money to list, and some never list. And each province has their own health budget and determines how much of that health budget goes to cover the cost of drugs. In general, about 6% of healthcare budgets cover the cost of drugs. Health concerns of the population vary from province to province, and so formularies will also vary from province to province. And it should also be noted that because the province agrees to reimburse the drug, it does not mean that it will automatically be available in the hospitals within the provinces. Hospitals also have their own budgets and health concerns and can choose to have a drug available in that hospital or not. And then in every province, There's a cancer agency, except Quebec, and each cancer agency has their own mandate. And some manage drug budgets for oncology for the province, while some have a mandate to provide recommendations of how the drug budget ought to be spent. So in the future, as new drugs come into the market, there's also going to be ongoing pressure for drug plan sustainability, healthcare system sustainability, and affordability. And the next slide. So Antonella touched on provincial coverage, and I'm just going to speak briefly about private coverage. So private drug coverage is eligible to people for additional coverage through their employer-sponsored drug plans, spousal or family coverage, or individually purchased drug coverage. And private insurance is meant to be a top-up to provincial insurance. And it's not really the focus of this webinar or of the drug pricing summit. So if you do need to have more information on private drug coverage, there are some webinars available on CCSN's website that you can look at. And that will bring us to conclusions.
Come back to me, do they?
And yes, back to you.
Okay, please. Just a comment. I know that Sabrina didn't mean to say this. The private plans will, in fact, be a part of our policy summit. I think she meant to say it is going to be part of a plan, but not part of this webinar. So please, we've done webinars at CCSN about the private plan, so please review them before you come to the summit as well. Just a couple of quick interesting things about CADTH that are not part of their formal, well, some of it's part of their formal work, some are pilots. They are doing a pilot with a patient navigator to see if, through CCAN, to see if that will help patient groups. So please feel free to get in touch with CCAN, look on their website, probably on the CADTH website as well if you'd like some help from their navigator. That is not a full-time position, so that's why I say it's a pilot. Another pilot that they're trying is to allow oncology physicians to actually put in submissions as well as patients in the same way that we've been doing to see whether that, and that apparently, the update we got a few days ago from CADTH is that pilot is going very well. Two other things, they're trying something at CADTH called the scientific advice, early scientific advice, where they're actually allowing companies to come in with early research ideas and protocols to give them some good advice about how best to develop their research in a way that gives them its best chance for CADTH, and I think that's a really good thing. One main difference between, and this is important to patient groups, between PCODER and CADTH will, I'm sorry, CDR will allow any patient group to apply no matter where their funding comes from or how much, and if they're deemed to be an appropriate patient group for the applications they want to put in, they'll be approved. Whereas PCODER continues to have a rule that if you get 50% plus one or more of your funding from one source, you will not be deemed a patient group to be able to put in an application. We can talk more about that at the summit. So just to finish my conclusions, and these are strictly mine, from all of what you've stayed on patiently to hear, this is a very complex system we live in. It's very multi-jurisdictional. There are layered structures. There's definitely unequal access across the country for some understandable and some not so understandable reasons in my editorial comment. There are many discretionary powers left to different civil servants in the way they do their work. Often those are not so transparent to us. There is certainly some patient engagement, but I would respectfully suggest that it's not always as meaningful across the board as it could be. And we certainly do not have universal drug coverage, either in who is covered or in what is covered across the country. And again, I would say some of that's understandable, some of it's not. In my view, it's understandable, but we've got to do better. And I hope we'll find some really great solutions at our summit about how to make some of that change. So the last slide, I think it's the last slide, if we could go to it, is just about our organizations. And again, I cannot thank my two partners in this crime for their great hard work, Sabrina Hanna and Antonella Scali, and their organizations for being such wonderful partners. If you would like to go back to see this webinar or any of the other webinars that we've done on private payers and other aspects, please go to our website. CCSN certainly has them, and I know Save Your Skin and Schizophrenia also have some interesting things that you could look at in preparation. So with that said, I'd be very happy if there are any questions. I think there is a question. Don't worry if there is no time. Can ask this at the summit. Well, it's okay. There's time. So my problem is I can't see the question. There we go.
Louise, I've got the question. I can ask it.
Would you?
With Quebec not participating, do you feel if they choose one HTA system or the other, do you see that until they determine what to do, that access delay issues are a risk with INESSS only doing reviews a few times a year? Could this be used as a delay tactic for PCPA even though they have the CDRP coder recommendation?
Would you like to try that one, Sabrina?
Well, I'm going to say yes. They're definitely going to use that as a delay tactic. And I think what we're concerned with is that the way that Quebec is making recommendations is going to set a precedence with the rest of the provinces involved in the PCPA. How it's going to play out exactly, I mean, is there going to be a role for INESSS in the future now that Quebec is participating at PCPA? That's a question we've all been asking ourselves. So I guess only time will tell.
Yeah, I agree, and I think that is a serious problem and a bigger problem, and we're going to talk about it in a lot of detail, I hope, at our policy summit, which is November 15th, 16th, by the way, is the whole question of what are we doing on the health technology assessment side? There are many, many ways to use a formula, many different formulas for deciding which health technology assessment you want to use. Canada has chosen one. We'll be talking about what that is, and we'll also be talking about some other possibilities that Canada might consider. So, Antonella, did you want to weigh in at all on that one, or should I go to the next question?
I think you've said more than I could say, so we can go on to the next question.
So it's to do with PCPA and the fact that PCPA does not have a formal process for patient involvement. Of course, my answer to everything is if an organization doesn't have one, make it up. So make up your own. What I do is I write to them and ask to have meetings with their staff and talk to them about the things that are concerning. In fairness to them, they have had some consultations with patients. We would really, I want to be clear that I think we as patients, most of us who think about a lot, know that the question of negotiations should stay private. I mean, they really should. I don't think it's right for them not to be. Am I still connected here, or did I get disconnected? Am I connected?
Yeah, you're good, Louise.
Oh, yeah. I'm sorry. My computer's telling me nasty stories. So I think that we don't want to know the absolute number that's negotiated. We would like to see, though, we would like to get an understanding of what other things PCPA is considering as good negotiating practice, I guess. They tell us, and we want to believe them, that they're looking at pay-for-performance ideas, that they're looking at sort of maximum payments for certain periods of time, or rollbacks if things are not working in some populations so well as we thought they would in the company. We'd like to know that what is going on is really not just dollars for dollars, because there are lots of other innovative ways that we could do this, and we'd like to see them do it. And we don't know that. We're not saying they aren't, but we just don't know because we don't get to find out about what goes on at the negotiations. And as I say, I don't want to know the specifics, but I'd love to know what kind of other creative techniques they're using. I also think it would be very useful if we had specific metrics for how long the entire process will take, and how long, given, you know, everything goes according to people doing what they said they do, how long each piece of that PCPA process will take generally, so that we at least have some sense of how long we're going to be waiting to get our hands on potentially some very important life-saving and life-enhancing drugs. And the last thing I would say is, I wish that PCPA would put in a process, and we've talked to them about bringing the patients in at the beginning of the negotiations, not as part of them, but just to explain from the patient's perspective what they think about these drugs, and some suggestions about what would be great to negotiate in terms of things that they think companies should be doing, shouldn't be doing. And that's different. That's quite a different discussion than the HTA discussion about whether something has value or not. We accept it has value, but there may be some nuances that should be considered. So that's a long answer, sorry. And I think we've only got about 3 minutes left. Is there another question? I can't see them, sorry. So if there is another question, oh, now they've come up again. Is there another question?
So there is a question about the slides being available after the presentation.
Yes,
if they'll be available.
Yes, they will tomorrow. And you know, as I said at the outset, what we're trying to do is set, amongst other things, is set the stage so that people who come to the summit, and I really hope you will not have to come in kind of at the starting line. So that, because really what we want to do at our summit is to have some really visionary, futuristic, creative, innovative thinking about how we can change some of what you know we have now, and how patients can be involved in doing that. So if you have any other sort of basic questions that you can't find anywhere else, please get in touch with us and ask them before the summit, so that you'll come in at a run when you arrive. Is that it for questions?
Louise, just to add to what you were saying, we will also be sending out some pre-read material to people who are registered, so that will also help provide some additional information in preparation.
Absolutely. Thank you. So if we have no other questions, I really cannot thank my 2 partners in this endeavor for all of their patience with me, and the great work that they've done getting ready for this, and the great work they're doing on the summit. And of course, I always thank Jackie Manthorn and Mona Forrest for their great leadership at CCSN. Well, I don't always, but I always should. But I am today, and I really appreciate that partnership as well. It's wonderful. So I hope we're all going to see you there, and I hope this has been useful. And Matt, thank you for all of your patience on the IT side.
Thanks, Louise. I'll just sign us off here, reiterating a couple things. Just want to thank all 3 of you guys for coming on, Louise, Sabrina, and Antonella, for coming on today. And I hope everything goes well at the Drug Policy Summit, and I hope everybody on the call is able to make it out to Toronto for that. There is information, if anybody's wondering, there's information on the front page of the CCSN website on how to register if you haven't done that yet. I believe there's still time. So go ahead and do that. Okay, yeah, confirmed. So go ahead and do that if you haven't yet. Now, just to reiterate again, this webinar is going to be available online tomorrow. There's going to be a full video on YouTube, and there's going to be slides on the SlideShare account. So if anybody wasn't able to make it today, please send them the links when you get them so that they can get ready as well, and review them closer to the date of the summit as well. So with that, hope everybody has a wonderful afternoon, and we'll talk to you next time.
Thanks so much.
Thank you.
Thank you.